Welcome to the deep dive. Today, we're taking a fast track into something really fundamental for both psychiatric and physical health, sleep disorders.
Yeah, it's a huge area.
And we're using a core source here, Kaplan and Sadock's comprehensive textbook of psychiatry, basically giving you the expert overview. So if you, the listener, need to get a solid handle on how specialists classify these things, how they diagnose them, manage them, well, this is your mission brief, really.
Right, from the basic mechanisms to the latest treatments.
But maybe before we dive into the disorders, we should set the stage. What is sleep, fundamentally?
Absolutely, we have to start there. Before we talk about what goes wrong, let's nail down three basic facts from the source. First, sleep is non-negotiable for your brain to work properly.
Okay.
If you don't get enough or the quality's bad, it impacts your thinking, your mood, your physical health. It's essential.
Got it. Essential. What's number two?
Second, it's not just one uniform state. Sleep isn't monolithic. We have different types of sleep, REM, non-REM, different stages. They're different qualitatively and quantitatively.
So different kinds of doing sleep.
Exactly. And third, and this surprises some people, sleep is definitely not passive.
Right. It feels passive, but it isn't.
Not at all. Your brain is highly active. There's a lot of metabolic activity going on, consolidating memories, clearing out waste products. It's an active process.
Okay. Essential, varied, and active. And I guess that explains why it's such a big deal when sleep goes wrong. These aren't just minor annoyances.
Oh, definitely not. They're dangerous. And they're incredibly costly. The textbook mentions figures like over $16 billion in direct annual costs just in the U.S.
Wow.
And that's before you even count the indirect cost links to things like hypertension, stroke, even major industrial accidents. Think Chernobyl, 3 Mile Island. Sleep deprivation was implicated.
Serious consequences. So how do experts even start to organize all these different problems? What's the classification system?
Good question. There are a few systems out there. Most physicians, especially in psychiatry, will primarily use the DSM, currently the DSM-5-TR. That's what we'll generally follow today since we're using a psychiatry text.
Okay, DSM focus.
But it's really important to know about the ICSD, the International Classification of Sleep Disorders, now in its 3rd edition, ICSD-3. Sleep specialists often prefer it because it's, well, more comprehensive, more detailed.
So DSM is the standard. ICSD has more detail. We'll kind of bridge both.
Exactly. The DSM often cross-references the ICSD and will pull in some of those richer ICSD subtypes where it helps clarify things.
Great. Okay, let's dive into the first big category then. Insomnia disorder. You mentioned this is where things have really shifted.
Hugely shifted. Yeah, this is probably one of the areas with the biggest paradigm changes from the older DSM-IV to the current DSM-5-TR. Really interesting for clinical practice.
Okay, what are these shifts? Lay them out for us.
All right, 3 key things. First, the idea of non-restorative sleep. Waking up feeling unrefreshed even after enough hours.
Yeah, I know that feeling.
Well, that's largely been removed as a defining feature of insomnia. It's still a symptom people report, of course. But diagnostically, feeling unrefreshed now points more towards hypersomnolence disorders, which we'll get to.
Interesting. Okay, so non-restorative sleep is out as a key insomnia criterion. What else?
The second and third shifts are really linked. We used to talk a lot about secondary insomnia caused by something else, like depression or chronic pain or anxiety.
Right. Treat the depression and the sleep gets better. That was the idea.
That was the old model. The big shift is that insomnia is now largely recognized as an independent primary condition. The idea that it's just a symptom of something else, that's mostly gone.
So instead of secondary, what's the term now?
Comorbid. We now view insomnia as comorbid with other conditions.
Okay, comorbid. What does that actually mean for treatment? Because that sounds like a huge change in approach.
It is massive. Clinically, it means if someone comes in with, say, major depressive disorder and significant insomnia, you don't just give them an antidepressant and hope the sleep fixes itself eventually.
Ah, so you tackle both at once.
You tackle both.
Yeah.
Directly. You initiate treatment for the depression, absolutely, but you also initiate specific treatment for the insomnia right away, usually non-pharmacological first, like CBKI. Experience shows patients get better faster and more completely this way.
That's a really practical takeaway for anyone listening. Treat the insomnia itself. Don't wait. Okay, so what are the actual diagnostic criteria for insomnia disorder now under DSM-5-TR?
All right, so you need a predominant complaint of dissatisfaction with sleep quantity or quality associated with one or more of these, difficulty initiating sleep.
Okay, trouble falling asleep.
difficulty maintaining sleep, so frequent awakenings or trouble returning to sleep,
Waking up in the middle of the night.
or early morning awakening with an inability to return to sleep.
Waking up way too early.
Right. And in kids, it might look like resistance to going to bed or needing a caregiver to intervene. Now, the crucial part for chronicity, this sleep difficulty has to occur at least 3 nights per week.
3 nights a week.
And it has to have been present for at least 3 months.
3 months. So it's not just a bad week.
Exactly. It's persistent. And importantly, this difficulty occurs despite having an adequate opportunity for sleep. You can't diagnose insomnia if someone's just pulling all-nighters studying, right?
Makes sense.
No.
Opportunity has to be there. Now, you mentioned the ICSD has richer subtypes. The source talks about a couple that really highlight how our own behavior or thoughts can drive insomnia. Can you explain psychophysiological insomnia?
Yeah, this is a classic one. It's basically conditioned arousal. The person starts associating their bed, their bedroom, even the whole bedtime routine, not with sleep, but with frustration, anxiety, and wakefulness.
So the bed itself becomes the trigger.
Precisely. They get into bed, and instead of relaxing, their mind starts racing. They worry about not sleeping. They're trying too hard, which creates performance anxiety about sleep.
And the clue you mentioned, sleeping better elsewhere.
That's a huge clue. They often report, I sleep fine in a hotel, or I fell asleep on the couch, no problem, because those places don't have that same negative conditioned association. The bedroom equals frustration.
Fascinating. And then there's the one that sounds almost unbelievable. Paradoxical insomnia.
Ah, yes, formerly called sleep state misperception. This is where there's a major disconnect between objective reality and subjective experience.
How so?
Well, you bring the person into the sleep lab, hook them up to the polysomnography machine, and objectively, they might be sleeping, say, 6, even 7 hours, maybe a bit fragmented, but substantial sleep.
Okay, objectively sleeping.
But subjectively, they report sleeping terribly. They might swear they only slept for an hour or two or not at all. Their perception is that they were awake all night.
The book mentions a case, Mr. M, a veteran, who had this. Severe complaints, but the sleep study was pretty normal.
Exactly. That case highlights the dilemma. His subjective report was severe suffering, significant distress about his lack of sleep. But the objective data didn't fully match that severity.
So, why treat it if technically they are sleeping?
Because the suffering is real. The anxiety, the frustration, the impact on their daytime functioning based on their belief they didn't sleep, that's what needs treatment. It forces us to really consider the patient's lived experience, not just the numbers on the machine.
That's a profound point about balancing objective and subjective. Okay, let's talk treatment for insomnia. The source really emphasizes non-drug approaches first, specifically CBTI.
Absolutely. Cognitive behavioral therapy for insomnia, CBTI, is the undisputed first-line treatment. Why? Because its effects are durable. Medications can help short-term, but CBTI gives people skills that last.
And what are the key parts of CBTI? The source mentions stimulus control therapy.
Right, that's Butzen's classic deconditioning technique. It's all about reassociating the bed with sleep, and only sleep.
How does that work in practice?
The rules are pretty strict. Only go to bed when you actually feel sleepy. Use the bed only for sleep and sex. No reading, no TV, no scrolling on your phone in bed.
Okay.
And crucially, if you get into bed and you're not asleep within, say, 15, 20 minutes, or if you wake up and can't get back to sleep and start feeling frustrated, you must get out of bed.
Get up, even in the middle of the night.
Yes.
Right.
Go to another room, do something quiet and relaxing in dim light until you feel sleepy again, then return to bed. The goal is to break that cycle of lying awake in bed feeling frustrated. Don't just lie there tossing and turning.
Break the negative association.
Bias.
And the other component, sleep restriction therapy.
That sounds harsh, like you're telling people not to sleep.
Ah, yeah, it sounds counterintuitive. But it's very effective. It's Spielman's technique for consolidating sleep and increasing sleep efficiency.
Efficiency, meaning the percentage of time you spend in bed actually asleep. Let's say someone spends 8 hours in bed, but reports only sleeping for 5 hours. Their sleep efficiency is low, around 62%.
All right.
With sleep restriction, you'd initially limit their time in bed to closer to the amount they're actually sleeping, say 5.5 hours.
But wouldn't that make them more tired?
Initially, yes, possibly, but it also builds up a stronger homeostatic sleep drive. So during those 5.5 hours they're in bed, they're more likely to sleep deeply and continuously. Their sleep becomes consolidated.
Ah, so you trade quantity for quality. temporarily.
Exactly. Once their sleep efficiency improves, say, they're sleeping soundly for almost all of that 5.5 hours, then you gradually start extending the time allowed in bed, bit by bit, as long as efficiency stays high.
I see. Plus, there's a cognitive part too, right? Tackling bad thoughts about sleep.
Definitely. Cognitive therapy challenges those maladaptive beliefs. Things like, I absolutely must get 8 hours of sleep, or tomorrow will be a disaster, or there must be something physically wrong with me because I can't sleep. We work on reframing those thoughts.
Makes sense. Okay, so that's insomnia. Let's flip the coin and talk about sleeping too much or being excessively sleepy. Hypersomnolence disorder.
Right, so hypersomnolence disorder is defined by excessive sleepiness, despite getting what should be an adequate main sleep period, usually defined as 7 hours or more for adults.
So it's not just because they stayed up late, they're sleeping enough but still sleepy.
Correct. And this sleepiness causes significant distress or impairment. It's presumed to stem from some kind of neurological issue with sleep-wake regulation, not just behavior.
What are the key symptoms we look for? Criteria mention needing one of three things.
Yes, again, occurring at least 3 times a week for 3 months. The symptoms are 1. Recurrent periods of sleep or lapses into sleep within the same day, like needing naps frequently.
Okay, naps aren't refreshing.
2. A prolonged main sleep period of more than 9 hours per day that is non-restorative. They sleep long, but still wake up feeling tired.
9 hours plus, still tired.
Or 3. Difficulty being fully awake after an abrupt awakening. This is what we call sleep inertia.
Sleep inertia, that groggy, confused feeling.
Exactly, but often more severe or prolonged than usual morning grogginess. Difficulty thinking clearly, feeling disoriented for a significant time after waking up. That's a key feature.
The source also mentions a really specific, rare variant, Klein-Levin syndrome.
Ah, yes, Klein-Levin. It's rare, typically affect adolescent males. It involves recurrent episodes, sometimes lasting days or weeks, of extreme hypersomnia sleeping 18-20 hours a day.
Wow.
And it's coupled with other striking symptoms during the episodes, like cognitive changes, compulsive overeating, megaphagia, sometimes hypersexuality, and general disinhibition. Then between episodes, they're typically completely normal. Very strange.
Definitely sounds striking. Okay, moving from general hypersomnolence to a very specific condition, narcolepsy. What defines this?
Narcolepsy is characterized by an irresistible need to sleep or actual daytime lapses into sleep, often called sleep attacks. Classically, we talked about a tetrad of symptoms.
The tetrad.
Excessive daytime sleepiness, which is universal, then cataplexy, which is highly specific, and then sleep paralysis and hypnagogic hallucinations, which are common but less specific.
And the big discovery here relates to a specific neurochemical.
Yes, this was a huge breakthrough. Narcolepsy, particularly type 1 with cataplexy, is strongly linked to a deficiency in hypocretin, also known as orexin.
Orexin. What does that do normally?
It's a neuropeptide produced in the hypothalamus, and it plays a critical role in stabilizing wakefulness and suppressing REM sleep. When you lose the neurons that make it possibly due to an autoimmune process, your sleep-wake states become unstable. Wakefulness intrudes into sleep, and REM sleep intrudes into wakefulness.
That explains the symptoms. Let's focus on cataplexy. It sounds dramatic.
It can be. Cataplexy is a sudden, brief loss of voluntary muscle tone. It can be subtle, like jaw slackening or head nodding, or it can be a complete collapse to the floor.
And it's triggered by something specific.
Almost always triggered by strong emotions, typically positive ones like laughter, excitement, or surprise, but sometimes anger or other strong feelings too. Critically, the person remains fully conscious during the event. They know what's happening but can't move.
Conscious but paralyzed by emotion. Wow. How is narcolepsy definitively diagnosed? You mentioned a test.
Yes, diagnosis requires that persistent daytime sleepiness plus at least one of three things, either clear-cut cataplexy
Okay.
or measured hypocretin deficiency in the cerebrospinal fluid.
Which requires a spinal tap.
Right. Or specific findings on sleep testing, specifically the multiple sleep latency test, the MSLT.
The MSLT, what does that show in narcolepsy?
The MSLT involves a series of scheduled nap opportunities during the day. We measure how quickly the person falls asleep, that's the sleep latency. In narcolepsy, we typically see a very short mean sleep latency, usually 8 minutes or less.
So they fall asleep really fast in the naps.
Very fast. But the other key finding is the presence of SORM sleep onset REM periods. Normally, REM sleep doesn't occur until maybe 90 minutes into sleep. In narcolepsy, because REM is poorly regulated, the person often goes directly into REM sleep or very close to it at the start of these naps. Seeing 2 or more SORMs on an MSLT is highly indicative of narcolepsy.
That direct jump into REM is the giveaway. What about treatment? Modafinil is mentioned.
Modafinil, or armodafinil, is often first line for managing the excessive daytime sleepiness. Traditional stimulants are also used, but for cataplexy, the real game changer has been sodium oxybate.
Sodium oxybate. Why is it so effective for cataplexy?
It's remarkably effective. It's actually GHB, taken at night in divided doses. It helps consolidate nighttime sleep, improving its structure, and somehow this leads to a dramatic reduction in daytime cataplexy episodes, as well as improving sleepiness for many.
Interesting. A nighttime drug helping daytime symptoms. Okay, let's shift gears again. Now, thinking about the mechanics of breathing during sleep-related breathing disorders, apnea and hypopnea.
Right. Apnea means complete cessation of airflow for at least 10 seconds in adults. Hypopnea means a significant reduction in airflow, also for 10 seconds or more, usually coupled with an oxygen desaturation or an arousal.
And the source emphasizes visualizing the difference between the main types. Obstructive first.
Obstructive apnea is the most common. Think of it like trying to suck air through a pinched straw. The airway, usually the pharynx, collapses or gets blocked, but the person's chest and diaphragm are still working, trying to breathe against that blockage. Respiratory effort continues, but no air gets through.
Effort without airflow. Got it. Then central apnea.
In central apnea, the problem isn't to block it, it's the drive to breathe from the brainstem. The respiratory effort itself decreases or stops altogether, so there's no signal being sent to the breathing muscles, no effort, no airflow.
Brain just stops telling the body to breathe momentarily.
Exactly. And then there's mixed apnea, which usually starts as central. The effort stops and then transitions into an obstructive event as the person tries to resume breathing against a collapsed airway.
Okay. Obstructive, central, mixed. The most common type overall is obstructive sleep apnea hypopnea, or OSA. And the health consequences here are pretty stark.
They are severe. OSA is incredibly common, especially with rising obesity rates, and the comorbidities are frightening. The source notes things like a 60% prevalence of hypertension in people with OSA.
60%.
Yeah. Plus strong links to heart failure, stroke, arrhythmias, diabetes, and also significantly higher rates of psychiatric issues like depression and anxiety. Untreated OSA is a major health burden.
So what's the gold standard treatment? We see people using machines.
That's positive airway pressure, or PAP therapy, most commonly CPAP, continuous positive airway pressure.
CPAP, how does it work?
The machine delivers pressurized air through a mask, and that constant pressure acts like a pneumatic splint. It physically holds the airway open, preventing it from collapsing during sleep.
Like inflating a balloon in the throat, basically.
Sort of, yeah. It keeps the passage clear. There are variations like BiPAP, bilevel, or APAP, auto-titrating, but the principle is the same. Maintain airway patency. It's highly effective when used properly.
Though adherence can be an issue, right? Other options.
Adherence is key, yes. Other options include oral appliances that reposition the jaw, positional therapy for people whose apnea is worse on their back, and various surgical procedures, though PPA is generally preferred first.
All right, let's move to our internal clocks. Circadian rhythm sleep-wake disorders. This isn't about sleep quality per se, but about timing.
Exactly. These disorders result from a mismatch, a desynchrony between the person's internal biological clock and the sleep-wake schedule they need or want to follow.
And that internal clock resides where?
In the suprachiasmatic nucleus, or SCN, a tiny region in the hypothalamus. It's our master pacemaker, driven largely by the light-dark cycle.
So what happens when that clock is out of sync? What are the main types?
Well, you have delayed sleep-wake phase disorder. These are your classic night owls. Their internal clock runs late. They naturally feel alert later in the evening, have trouble falling asleep until maybe 2, 3, 4 a.m., and then struggle to wake up for work or school in the morning.
The perpetual struggle against the 9-to-5 world.
Pretty much. Then you have the opposite. Advanced sleep-wake phase disorder. These are the extreme early birds, or larks. They get sleepy very early in the evening, maybe 7 or 8 p.m., and wake up correspondingly early, like 3 or 4 a.m., often unable to get back to sleep.
Both sound disruptive if they don't fit your life schedule.
They can be. And then perhaps the most challenging, socially and health-wise, is the shift work type.
Because they're constantly fighting their biology.
Constantly. Working nights or rotating shifts forces them to try and sleep when their internal clock is screaming wake up and work when it's screaming sleep. This leads to chronic sleep deprivation, excessive sleepiness on the job.
And increased risks, you mentioned.
Huge risks. The data shows significantly higher rates of accidents and errors, particularly during those biological low points, typically between 3.000 and 50 a.m. for most people. It takes a real toll.
How do you treat these timing issues? Seems tricky.
The key is understanding how to manipulate the internal clock, primarily using light. Light is the most powerful synchronizing agent, or Zeitgeber.
So using light strategically.
Precisely. We need to know the timing of the person's core body temperature minimum, or nadir usually occurring a couple of hours before natural wake-up time. Bright light exposure before that nadir promotes a phase delay. It pushes the clock later.
Light before the lowest point makes you later.
Right. Bright light exposure after the nadir promotes a phase advance. It pulls the clock earlier. So for a night owl, you'd want bright light exposure soon after waking up in the morning to pull their clock earlier. For an early bird, you might use evening light avoidance and maybe low-dose melatonin.
Carefully timed light therapy. Fascinating. Okay, next section. Parasomnias. These sound weird. State boundary violations.
Huh. Yeah, that's a good way to put it. Parasomnias are undesirable physical events or experiences that occur during entry into sleep, within sleep, or during arousal from sleep. It's like one state of being wakefulness. NREM sleep. REM sleep intrudes improperly into another. Disorders of partial arousal.
Let's break them down. NREM arousal disorders first. From deep sleep.
Right. These arise typically from stage N3 or slow wave sleep. The main ones are sleepwalking, somnambulism, and sleep terrors.
Sleepwalking people doing complex things while asleep.
Yes, things like sitting up in bed, walking around, sometimes even more complex behaviors like eating or leaving the house. The person is essentially unconscious, eyes often open but glassy, unresponsive. Common in kids, less so in adults.
What's the advice if you encounter someone sleepwalking? Wake them up.
The main thing is safety. Don't try to forcefully wake them, as it can cause confusion, agitation, sometimes even aggression. The best approach is to gently guide them back to bed without waking them if possible. Ensure the environment is safe, lock doors, remove obstacles.
Gentle guidance, safety first. Okay. And sleep terrors. How are they different from nightmares?
Sleep terrors are also from deep NREM sleep. They involve a sudden arousal with intense fear, often a piercing scream, sitting bolt upright, signs of autonomic panic like sweating, racing heart. But the key differentiator is amnesia. The person usually has little or no recall of the event itself the next morning.
So terrifying for anyone witnessing it, but the person doesn't remember it.
Exactly. Nightmares, on the other hand.
Those come from REM sleep, right?
Correct. Nightmare disorder involves recurrent, frightening dreams that occur during REM sleep. And unlike sleep terrors, the dreamer usually wakes up fully and can vividly recall the disturbing dream content.
This can cause problems beyond just the bad dream.
Oh, yeah. Frequent nightmares can lead to anxiety about falling asleep, fear of having another nightmare, which can then cause avoidance of sleep and develop into a secondary insomnia.
Makes sense. Now, what about REM sleep behavior disorder, RBD? This sounds potentially dangerous.
It is. RBD is fundamentally a failure of normal REM sleep atonia.
Atonia, the muscle paralysis.
Exactly. Normally during REM sleep, while our brains are highly active dreaming, our voluntary muscles are paralyzed, presumably to prevent us from acting out those dreams. In RBD, that paralysis fails.
So they hacked out their dream.
Literally, they might punch, kick, jump out of bed, yell, physically enacting whatever is happening in the dream. This obviously poses a high risk of injury to themselves or anyone sleeping with them.
Scary. How is RBD treated?
Clonazepam is often very effective in reducing the problematic behaviors, essentially helping restore some muscle tone suppression. Melatonin is also used. It's also important because RBD can sometimes be an early sign of underlying neurodegenerative diseases like Parkinson's.
Important connection. Okay,
Yeah.
one more category often discussed here. Movement disorders, specifically restless legs syndrome, RLS.
Right. RLS is technically classified as a movement disorder in the ICSD, though DSM puts it with parasomnias. The core feature is an irresistible urge to move the legs, sometimes arms or other parts too.
And it feels unpleasant.
Usually, yes. People describe it as creepy-crawly, itching, pulling, aching. Hard to pin down, but definitely uncomfortable. And there are key diagnostic features.
Which are?
The urge to move is typically worse during periods of rest or inactivity, like sitting or lying down.
Worse when resting.
It's partially or totally relieved by movement, like walking or stretching.
Better with movement.
And it's usually worse in the evening or at night. Those three things are crucial.
Worse at rest, better with movement, worse at night. How's it treated?
Treatment often involves addressing underlying iron deficiency if present. Pharmacologically, dopaminergic agents like pramipexole or roperidol are often first line and very effective.
Dopamine connection. Interesting. And finally, just to mention them, the source lists a couple of really intriguing ones. Exploding head syndrome.
Sounds traumatic, right?
Yeah.
It's actually a perception of a sudden, loud imagined noise, like a bomb exploding, a gunshot, a cymbal crash, right as the person is falling asleep or waking up. It's startling, maybe frightening, but benign, not a real explosion.
Good to know. And recurrent isolated sleep paralysis.
This is when you wake up or are falling asleep and you're conscious, but you find you cannot move or speak. It can last seconds to minutes. It's often accompanied by hypnagogic or hypnopompic hallucinations, dreamlike visions or sounds, which can make it terrifying. Isolated episodes are common, but recurrent ones define the disorder.
Definitely sounds terrifying. Okay, we've covered a lot of disorders. How do clinicians actually diagnose these things? What are the tools? The interview is still key, right?
Absolutely central. The clinical interview is the foundation. Talking to the patient, getting their detailed history, understanding their sleep schedule, habits, symptoms, talking to bed partners if possible about snoring or movements. That subjective report is where it all starts.
But sometimes you need objective data.
Often, yes. Especially for suspected breathing disorders, narcolepsy, or certain parasomnias, that's where the specialized tests come in.
Can you give us a quick rundown of the main ones?
Sure. The most comprehensive is polysomnography, PSG. That's the overnight sleep study done in a lab. We monitor brain waves, EEG, eye movements, EOG, muscle tone, EMG, heart rhythm, ECG, breathing effort and airflow, oxygen saturation, the works.
The full picture. When is PSG indicated?
It's the gold standard for diagnosing sleep apnea, essential for narcolepsy workup, usually done the night before an MSLT, sometimes used for periodic limb movement disorder, unusual parasomnias, or suspected nocturnal seizures.
And the MSLT we already discussed.
Right, the multiple sleep latency test, done the day after a PSG, specifically to measure daytime sleepiness objectively and look for those sore EMPs characteristic of narcolepsy.
Are there simpler tools too? Not everyone needs a full lab study.
Definitely. Actigraphy is very useful. It's like a sophisticated wristwatch that monitors activity and rest patterns over days or winds. It gives a good sense of real-world sleep-wake cycles, much cheaper and easier than PSG.
Like a high-tech sleep diary.
Exactly. And simple sleep diaries or logs kept by the patient are still incredibly valuable for tracking patterns and subjective experiences over time. Plus, standardized questionnaires are widely used.
Like the Porters.
The Insomnia Severity Index, ISI, helps quantify the severity of insomnia symptoms, and the Epworth Sleepiness Scale, ESS, measures subjective daytime sleepiness levels, how likely you are to doze off in different situations. Very helpful screening tools.
Great overview of the toolkit. So, bringing this all together, wrapping up our deep dive based on this chapter, what's the main takeaway message?
I think the core message from the source is twofold. First, sleep disorders are common. They're often primary conditions in their own right, but they are also incredibly intertwined, highly comorbid with almost every other area of health, psychiatric, neurological, general medical.
You can't really separate sleep health from overall health.
You absolutely cannot. The source mentions insomnia comorbid with a mental disorder as perhaps the most common form seen in psychiatric practice. The second main takeaway, though, is optimistic.
Oh, how so?
With proper diagnosis and appropriate treatment, which is often multidisciplinary and really should prioritize non-pharmacological approaches like CBTI when possible, most sleep disorders can be managed effectively. And successful management leads to really dramatic improvements in a person's overall well-being and quality of life.
Effective treatment makes a huge difference.
Huge. Knowledge is power, but applied knowledge is what changes lives here.
Okay, so for you, the listener, what does this deep dive boil down to? I think the source confirms something we intuitively know but maybe don't prioritize enough. Getting a good night's sleep isn't a luxury. It's as vital to your health as eating well and exercising. You just can't neglect it.
Absolutely fundamental. And maybe as a final provocative thought to leave you with, think back to that concept of paradoxical insomnia. Mr. M, remember, objectively, his sleep wasn't that bad on the PSG, but his subjective experience was one of severe suffering.
Right, the disconnect.
It really raises a crucial question that applies way beyond sleep medicine into all areas of health assessment. How do we, as clinicians, or even just as human beings trying to understand each other, best balance that objective, measurable data we can gather against the patient's deeply felt, sometimes seemingly contradictory subjective reality? Where does the truth of their condition lie?
Finding that balance between the charts and the person's experience, that's a constant challenge. Definitely something to think about.
Indeed.
Well, thank you for joining us on this deep dive into the essentials of sleep disorders, drawing straight from the work of Dr. Sharaf Khanna, Dr. Kazai, and Dr. Hershkowitz in Kaplan and Sadock's text.
My pleasure.